Hi, this is Dr. Mike Barnes. This is our short video for week 3. It's on secondary trauma, and it's the signs and symptoms of trauma experienced by family members. And so we've been talking about this for a while, and we have kind of looked at the Diagnostic and Statistical Manual 5th edition criteria for post-traumatic stress disorder, and it says that anyone who has experienced a life-threatening event or witnessed it or had someone that they loved or a very close associate who's experienced a traumatic event all can show symptoms of post-traumatic stress disorder. And so I have shown kind of similar quotes to the one I'm about to show with one addition. And I've made it very clear since we've been talking about trauma that family members of individuals who have been experiencing significant addiction issues often report significant experience of it being traumatizing for them. And I showed a similar slide to this the other day. And really, these are 3 different quotes from family members, or one is actually a research finding that we did at Cedar when I was there prior to coming to Foundry. And we had asked all, it says an N of 260, but there was actually an N of about 350 family members who had come to a family education very similar to what you're experiencing now. And we asked them, is living with an addict traumatizing? And 74% said that they strongly agreed that they experienced their loved one's addiction as being a source of trauma for them. And 21% agreed. So when we put those numbers together, we're looking at 95% of all of the family members that we talked to in our study, and this was done probably 4 or 5 years ago, believed that living with an actively using addicted family member was traumatizing. Second was a quote that you've seen before. It's the mother of a 20-year-old daughter who is addicted to heroin. And this mother was part of a research project that we did at Sarasota Memorial Hospital many years ago. And I always use this quote because it has stuck with me for so long. And it's the pain in this mother's voice as she was kind of answering my questions in the research project. Her response was, "It's really been overwhelming. I can sit here calmly and talk now, but that's not the same as when I don't know where my daughter is or what's happening. I'm getting phone calls from someone on the street saying that she's been beaten or she's been raped. Really bad things are happening to her. It's not such a calm feeling when you get these phone calls, or you get phone calls in the middle of the night. I think there must be some sort of post-traumatic stress disorder for families going through this." And clearly, many families and family members talk about the fact that they believe that they have been traumatized, and that the symptoms are lasting and pervasive for them. The third one is actually a quote from a mother who was attending one of my presentations recently, and she sent me an email after the presentation, and in it she said, "My second son has mental health issues and is an addict. It has been very difficult for our family unit to understand where he is coming from, how this happened, etc. I often wonder if there will ever be a light at the end of this of his dark tunnel. He's now 37 years old, about 25 years into his dual illness. However, I see me in this segment of the webinar instead. I have never been diagnosed with PTSD, but what I read and followed along in your presentation, it was like I was being spoken to." And this mother's story is so common, and I really want to normalize the experience that oftentimes families and family members feel these symptoms, but they don't have a frame of reference for it in terms of trauma. And so going forward, again, if this fits, I think that would be really useful to kind of move forward in looking at your own trauma issues. And hopefully this will shed some light. And the rest of this material is from my research, my dissertation research. I say that except for this slide. This was from a presentation that Margie Schofield, who was one of my interns at Sarasota Memorial Hospital, and I we were doing an ethnography, really looking at family members who had loved ones with mental health issues and addiction issues. And in the ethnography, what the families told us was the things that were most traumatizing to them, or the sources of the trauma response for them, were the items that are on this list. And one of the ones that was really important, particularly this was for both parents of young adults with traumatic issues, but also for couples, for someone who was married to someone who had an addiction or or mental health issue. But this idea of shattered dreams, that they talked about how once that person became chronic and really became so negatively impacted, that their dreams about what a healthy marriage was or a healthy relationship would be began to shatter, and that the individual will never be who we thought they would be, not who they were before. Our relationship will never be what it was. And that shattering of dreams often is experienced as a shift from being hopeful to hopeless, associated with the individual's issues. The second, dangerous and out of control behaviors: yelling, threatening, violence, weapons, assault, all of those kinds of things. And that those are common experiences for family members with loved ones whose addictions are getting increasingly out of control. Legal involvement: police actions, DUIs, jail, prison. Commitment is someone who is committed against their will into a psychiatric facility because of psychosis or because of suicidality. Trips to the emergency room and unexpected crisis calls in the middle of the night. It's not unusual at all for families to be moving, about their business, and then there's a phone call that there's been an automobile accident. There's been, something, an overdose or something along those lines, that terrifies the family in most cases. Suicide attempts and suicidal ideation. And of course, suicidal ideation is the thought about hurting oneself. And typically, particularly for men and women tend to take medications as their primary source of suicide attempts. Men often are far more successful in suicide attempts in that they use far more dangerous methods, gunshots and things like that. The next to last is a loved one's victimization. Hearing of sexual assaults or physical assaults or injuries that have been incurred, or some of the more classic trauma, types of trauma that happen in a loved one's life. And then the last one is the co-occurring mental health issues: psychotic issues, depressive symptoms, bipolar disorder. And to be quite honest, we're seeing significantly more young people coming into addiction treatment with psychotic response due to very high rates of THC in the various cannabis-related products that are so popular today. So when I studied the secondary trauma of parents of children who had experienced a significant traumatic event, I developed what I called a set of axioms, or testable hypotheses, the things that we saw and the research participants saw and experienced. And I want to review those with you because I think these are the things that, whether it's a parent with a loved one who's been traumatized, or whether it's family members with addiction, so often we hear people talk about codependency and those things, and you're probably very aware at this point of my beliefs about that, and the beliefs that even codependency is really a trauma response. So the first testable hypothesis is that family members report having experienced emotional, cognitive, and behavioral symptoms that are similar to those reported by the primary victim or the primary trauma survivor. And so does the individual meet the criteria for post-traumatic stress disorder? Sometimes they do and sometimes they don't. But you have to remember that the criteria, you have to meet so many of the criteria in each area to meet the diagnosis. And these are the things that families tell me on a regular basis that they experience. So anxiety, fear, anger, that sympathetic nervous system response, the dysregulation of the nervous system. You're probably familiar with the marble map that I use, and that kind of very high into the fight-flight response symptoms that are very common. Intrusive thoughts about traumatic events, whether it's the things that were identified in the previous slide, or intrusive thoughts about whether your loved one gets to their AA meeting or gets to their doctor or takes their medication. But it's not unusual for family members to say that they're sitting at their computer at work and suddenly the only thing they can think about is their loved one and what they're doing. Many families talk about sleep disturbances, nightmares, flashbacks, a lot of intrusive memories of events in the past, arguments, fights, people storming out of the house, those type things. Family members talk about significant hypervigilance, feeling the need to control others, and when we really look at those, we remember that those are defense mechanisms that really evolve out of a shift from seeing the world as a safe place to seeing the world as a more dangerous place. And the more I can control the behaviors and thoughts and feelings of my loved one, the safer I can feel. Given the amount of love that everyone has for their family members, that's a really logical thing to do. It doesn't work very well, but it's a logical thing to do. Fatigue, dissociation. And remember, when I did not include the marble map in this presentation. I probably should have, but that idea of as the marble is rolling up the hill into more and more of a fight-flight response, which is the sympathetic nervous system, we get to a point at which we realize that there's really not much we can do about the circumstance except live with it, which is exactly what happens in a trauma. There's an element of powerlessness to that. And then the sympathetic nervous system turns off and the parasympathetic nervous system turns on, which is the nervous system that has to do with dissociation, being there physically but not being there emotionally, being there cognitively but not being there on a feeling level. Some people experience it as if they're kind of watching the interaction as if it were a movie, like they're outside of their bodies. The next is feeling detached or estranged from others. The idea that they're so exhausted, they're so focused on their loved one that they let important relationships go away, or people who have traditionally been a support system for them become less of a factor in their lives. We begin to see disruptions in marriages and disruption in long-term relationships. It's really part of that avoidance. There are avoidance of people and places that remind us of traumatic memories, and then there are avoidance of activities and avoidance of emotions that are reminders of the trauma. And family members talk about all of those. The next slide you've already seen if you've been in the program for a couple weeks. If this is your first week, clearly you have not. And so this was a research project. This is part of the same research project that Margie Schofield and I had done. And when we looked at all of the responses that the family members gave associated with their loved one's addiction and mental health issues. One of the things, and we had 40 hours of interviews, was that there were very common feelings and common defense mechanisms and kind of thoughts and cognitive responses and physical responses and behavioral responses that the vast majority of the families that were part of the study talked about. And so I would ask you to take a look at this slide and see how much of it you relate to. And so common feelings of anger and fear and grief and guilt, at times horror. This just can't be happening to our family. This is unbelievable. For some, it's the person's behavior is so out of control that there are moments of terror and at times being shocked by it. Elements of hurt, grief, kind of loss, depression, shame, and grief or guilt is feeling bad about what I've done. Shame is feeling bad about who I am at this point as a result of the things going on around me. Common defenses are the exact same ones that the addicted individual uses: denial, rationalization, intellectualizing, and projecting. And family members do this all the time. That idea that, well, this is a phase. This just can't be. I talk about my mother a lot, and her father was an alcoholic. And when I became a professional, we were talking about it one day, and I was trying to help her understand the chronic disease model. And she said, your grandfather wasn't an alcoholic. I mean, he had his problems with drinking, but he was allergic to it. He didn't have an illness. And so that it's more rationalizing on her part, the idea of there's a logical explanation for this that doesn't make it as bad as it might actually be. Intellectualizing, we have to get to the root of this. We have to find the primary cause of this so that we can fix it and get rid of it. And then the last one being projection, the idea that we're going to project it out onto other people. And the reason our son is having such problems with addiction is this girlfriend that he's had for a while. She's been a bad influence, or the divorce many years ago, or always, rather than saying, no, this person I love dearly has this illness, and it's really impacting me, and therefore we both have this problem, and it might be the same problem but in very different perspectives. That it's a way to project it away from us onto other people. Cognitions, they obsess over it. There's a great deal of uncertainty. They blame themselves. They blame others. They hold resentments. There are times they feel hopeless and helpless, and at times there's this incredible fear of the future. What's it going to look like a year from now? He's been through a couple treatments, and what's going to happen in the future? Not just for him, but for us as a family. How long can we hang together to do this? Common physical responses: sleeplessness, exhaustion, nightmares, a startle response. And a startle response is if you're kind of sitting there deep in thought and someone comes up behind you and taps you on the shoulder and you have that jump response. That's a very classic post-traumatic response. And then the last is common behaviors: hypervigilance, controlling self and others. And sometimes people control by trying to make other people do things. Sometimes the greatest source of control that people have is to isolate and to stay silent and to not, it's like holding your breath, hoping that if you don't try to do anything to make this person upset, that they will find a way to resolve this. Caretaking, which is like enabling and over-involvement, paying people's rents and things. Imposing structure, trying to kind of set up a recovery plan for the loved one, and then avoiding the triggers that they experience associated with the drug use and the other things we've talked about. And so when we did this study, we were not actually trying to study trauma. We were really just trying to find some really clear patterns that family members experience, and to use it then to help develop interventions to help families get better. But what we really found was that families were really talking about a trauma response. So you see at the bottom with the two arrows that the primary underlying issue was anxiety and worry and hypervigilance and control. And that those are clearly traumatic stress response. And that the last part was something that was part of the study, but it was part of the projection that they were all very upset with the medical community and the treatment community, and that they didn't feel that their loved one got very, very good care or very good treatment. And in some cases that's truly the case, and in others it's just part of that trauma response. So if number one is that all family members, not all, but a lot of family members experience post-traumatic symptoms, the second is that the longer the family kind of stays in the fight-flight response, and we call this physiological response. So the second axiom is, what is the impact on safety and the activation of the autonomic nervous system? And so, like I was just saying, because of the consistent experience of fight, flight, and anxiety, family members frequently experience a change in worldview or their perception associated with personal vulnerability, safety, and control. And that idea of when families are not in crisis, their worldview tends to focus on how do we maintain our value system, and how do we keep everybody in the family working towards their goals, and feeling good about themselves, self-actualization, and all of those things. But the longer the addiction lasts, and the longer the family stays in a fear response or an anxiety response, that worldview shifts to how do we make everyone a little less vulnerable? How do we make sure that everyone stays safe? And there was a book that was written in 1985 by Ronnie Janoff Bullman, and she was a professor at the University of Massachusetts at Amherst, and she said that while there's this physiological response, there's also this incredible cognitive response, and that in the United States that there tend to be these cognitive schemas associated with the world being relatively safe. Now, I think with a lot of what's going on in our world right now, that may not be as valid as it once was. But the three safety schemas that she talked about is that for the most part, we see the world as being a relatively safe and relatively benevolent place. That if we are responsible, and if we do the things that we're supposed to do, meaning the world is meaningful, then we can have some control over what happens to us. And the third one is that it's kind of like karma. Good things generally happen to good people. And so, when these traumas begin to happen, there is such an element of powerlessness and such an experience of being out of control that the world becomes not a safe and benevolent place, but a dangerous place. And that the world isn't meaningful, and that even if I'm the most responsible person in the world, bad things can still happen to people I love. And so that the world's not only dangerous, but it's pretty random. And we have to do everything we can to try to limit how random it is. And so the good things happen to good people isn't accurate, because every day really good people get cancer, and really good people are in car accidents. And so the reality of how dangerous the world is also helps that shift for family members to focus on maintaining safety. And so following a traumatic event, families commonly experience a shift in attitude and belief that represents this focus on safety related to self and others. And so if you look at the bottom of this page, these are the things we're going to talk about probably not next week, but the next week after that. And this idea that due to concerns about safety and vulnerability, families tend to really engage in protective behaviors. And so the more fear I have of my loved one dying of an overdose, the more hypervigilant and controlling I'm going to be. The more I don't feel that I can physically keep and maintain the level of vigilance that is needed, I'm going to begin to enable more. I'm going to become more overprotective, more defensive. And families say to me all the time, well, but if I don't enable, what if they die? And I always say the same thing to them, that they're not dead today, so they're doing, they're struggling. They're in treatment, and so this idea of, as families begin to recognize the kind of systemic impact of this, not only on the client but on the family, that the more the family can begin to talk to their loved one about the need for family healing. And so I always talk about enabling, and we'll talk about this in a couple weeks. But if we tell family members, you need to just stop enabling, that's like Nancy Reagan telling an addict to just say no. That if we're not going to teach people how to do that, or really begin to help people understand why, even though it seems like a logical thing that we do, and it really is what loving, attached people do, is they take care of each other. But to begin to look at how when I enable, it allows me to feel more in control, or it allows me to feel that I'm doing a loving thing for the person that I clearly love. But when most people really begin to look at it, it's a very anxious process, that there's a lot of uncertainty, and people will talk about, my chest got tight and my breathing changed, and I knew if I said no that he would be really angry with me. And so people often do these protective activities more to protect themselves, once they can get past that, to really begin to look at more so than helping their loved one, even though they're desperately trying to help their loved one. So this is the second. So the first is people have symptoms. The second is those symptoms lead to this inability to manage the autonomic nervous system, and therefore people feel vulnerable, a lack of safety, and very much out of control, which then, we use the mobile analogy, which forces the mobile to kind of evolve in order to keep everyone as safe as possible. The third axiom is that perception becomes more important than reality to the family. And so we tend to look at this model. This is called the ABCX model, and it was developed by a psychologist by the name of Reuben Hill back right after World War II. And he says that every family, every human system has these sort of three mechanisms that we call stable, that develop a set of interactional or stable patterns. And so that when we have stressors, we use resources that we have, and we'll talk about what some of these are in a minute, and our perception of what the problem is will dictate or guide us in which resources would be the appropriate resources to solve the problem. And it always reminds me of a student asking me why I think clients change. And I was thinking about this slide, and particularly the importance of perception. And I said, people change whenever they realize that the problem that they're trying to solve isn't the problem that they have. And the idea that they change when they can change their perception of what that stressor is about. And that allows them to utilize different resources than the resources that they currently have. So if you look at the text on that slide, family members' perceptions or experience of the stressor or the anxiety associated with these traumatizing events influence how the family system interacts. It influences coping mechanisms and the degree of emotional consequence experienced. And my favorite statement is the one by Shaw and Halliday that said, "The crisis is not the problem. It's the family's constraining beliefs that restrict alternative views about the crisis that becomes the problem." How we understand what it is that stressor is will dictate the resources that are needed to solve it. If we continue to maintain the same perception, we will generally tend to use the same solutions over and over and over. In family therapy, we call that a first-order change. And that simply means that we don't try new things, we just try the ones that we think are the right ones harder. And so we really want to begin to help you to understand that how you understand your loved one's addiction, the causes of it, the consequences of it, really do limit your use of solutions. And it's not unusual, we talk about this a lot, that families will ask me, what do you think we should do? And I used to just tell them, here's what I think you should do. I give them resources. And I began to realize that was not a positive thing to do, that most often families would say, well, we've already tried that and it doesn't work. Or let me tell you why I don't think that's the right solution. And so as I was giving them solutions or resources, if they didn't meet the family's perception of the problem, they wouldn't do them. And so I changed my tact, and when someone asks me, what do you think we should do? I usually say to them, if I tell you, will you do it? And what that does is open up a very important kind of secondary discussion. And that's really to find out, why are they asking? And if they're really just trying to see if their perception and the resources that they use or solutions that they use are consistent with mine, then they can be assured that they're, they can feel supported in that process. But a lot of times, that's not the case. So if we look at the same three things, so stressors for any family can be developmental transitions, having 4 kids and kids going off to college and kids going into high school and another kid going into middle school, and those kinds of things can be a really kind of stressful scenario for families. Addiction, trauma, illness, someone has a serious disease, something along those lines. And so employment changes, loss of jobs, financial changes. Think of COVID and how the current financial situation for so many people. Legal issues, relationship issues. And so if you look at these, they could all be individual consequences or individual stressors that families have to deal with. But I want you to think about this list when we look at the next slide. And so where does a family, or where do individuals in a family get their concept or perceptions associated with those stressors that we're talking about? So let's just use addiction, or use trauma, or illness, any of those. And so our family of origin gives us schemas associated with illness, schemas associated with how do we deal with chronic illness, how do we deal with addiction, how do we deal when there are losses, what is our own personal trauma history. And so if we have a history of trauma, it's going to influence the perception that we have in trying to understand what our loved one is going through. Our own adverse childhood events. Did we grow up in a family with significant addiction or mental health issues or divorce? What were the things that, was there a lot of arguing? Was this a very successful family where, the needs of the collective were more important than the needs of each of the individuals in the family? One's own personal addiction history. If someone's in recovery, how does that influence how they deal with their loved one? Cultural issues of race and religion, gender, class, and those are all, we're really looking at issues of cultural trauma and transgenerational trauma associated with culture and class that impacts our perception of not only problems but of solutions. Relationship history, marital status, and then extended family influence. And so all of those things have to be considered. And even though we don't think about it, like where did our own belief systems come from? And then if we look at existing resources, intellect, emotional intelligence, like were we taught to be emotional? Did we grow up in a family that really allowed us to develop a secure attachment? Or are we anxious, or are we avoidant? How do we manage our own autonomic nervous system and kind of our own emotional or our affect management? What kind of boundaries did we grow up in? Open? Were we allowed to get social support? Were we allowed to communicate clearly? Did we know what we were supposed to be doing? Or was it a pretty chaotic or pretty controlling environment? Financial security, do we have the resources, insurance? Do we have a job where we can go to an employee assistance program? Are we employed? And then do we have extended family support? And so if we look at this issue, if our perception doesn't allow us to utilize those resources that we have, to be able to seek out assistance or seek out therapy or have the autonomic nervous system regulation to be able to have really difficult conversations, then it's going to be more difficult to solve that problem or to solve the crisis. And so the next slide is of what we call the double ABCX model. And so this is, clearly you've seen this one here. And so if the perceptions and the family doesn't have the resources, and if their understanding of the source of the stressor or what is needed to deal with that stressor allow them to utilize the resources that they have, then they solve that problem and they do not move into a crisis stage. But things like trauma and things like addiction, mental illness, physical illness, chronic disease, are things that even sometimes with the best perception, that the family has to develop new resources or new solutions, or they have to begin to change their understanding of that, the nature of that stressor, so that they can use these. So that if the family does not resolve the crisis, which is the addiction or the trauma or their response to it, they move into a more post-crisis or crisis-oriented response. And so if you think about these issues of addiction and trauma, and so where there's addiction or there's chronic trauma or there's chronic illness, there are often employment changes. There are often financial shifts. There are often legal issues and relationship struggles. And so when McCubbin and McCubbin and Patterson were the people who took Hill's original work and said, well, what happens if they don't solve it? And so what we begin to see are, rather than the stressor that brought them or that created the crisis, but now the family is not only dealing with the original crisis or the original stressor, but now they're dealing with all the pileup. And so what we would call pileup stressors. And so if the issue is addiction, are they now dealing with the loss of jobs? Are they now dealing with chronic pancreatitis or medical issues, hospital visits for overdose, ambulance travel, financial struggles? Does the family have the same resources as time goes on, as they continue to struggle with that? And so they may not have the money that they had before. They may not have had the insurance that they had the time before. They may be exhausted, so they've lost some of that emotional kind of resource that they had. The longer they go, the more they stay in that fight or flight response that we've seen. So, and then perceptions get more and more rigid over time. And so what we do find is that the longer families go without solving the problem, that they don't become more flexible and more open to new ideas. They generally tend to become more rigid and less flexible to new ideas. And so again, most of our clients don't come to us in this early stage. They come to us in this stage. So those are the things that we would want families to really begin to take a look at. How has the trauma associated with your loved one's addiction altered your perception about safety and vulnerability? How has it altered what resources you believe you have available to you? How many new crises and new problems are you working with on a daily basis? And again, that's why we talk about entire family healing. These are not things that are just impacting the loved one with the addiction. It's impacting everyone. And that's why I include a picture of the mobile. And as it's beginning to shift, the rules begin to shift to be more rigid and more secretive, and the roles and routines and boundaries become more, we'll talk about this in the next slide, more closed and more rigid. So this is why we're not just talking in this process about your loved one's addiction, but really focusing on how that addiction has impacted all of the people in that family, so we can begin that healing process. And the last of the axioms is what we called in my dissertation and in the research that we did subsequent with Jeff Todall and my wife, who was my first wife, that was part of the family when Patrick got hit by the car. And we really began to look at the secondary trauma issue, was that the longer that family stays in this second ABX, the double ABX, and so let me be really clear. What that means is the longer the family is trying to solve this crisis, trauma and addiction, whatever that is, and they begin to organize their daily interactions in ways that allow them to stay as safe as possible while continuing to try to solve that problem. So we call that organizing around the problem, or the crisis, because it's not going away. The family's trying just as hard now as they tried back here to help their loved one. They just get to the point where they generally keep trying the same things over and over. And that's why I'm so thrilled that you guys are really participating in this program. So at that point, we begin to see significant organizational shifts, and we'll talk about those in a minute. See a lot more conflict between family members, a lot more anger and resentment, emotional distance, emotional intensity, shifts in intimacy for family members, shifts in parenting, shifts in decision making. And so the things that may have been some real resources and strengths for the family early, before the addiction became really a crisis or a trauma, now begin to deteriorate. Resources begin to deteriorate. And so we see triangulation, where the trauma survivor or the person in the family with addiction kind of becomes the focal point of the family. Adults, if this is an adult child, the parents often have different ideas about how to help that person, so they begin to have increased conflict and arguments as they're trying to help this person. Siblings for this person probably are not getting as much attention as this person is getting. I know a family where the siblings don't bring their kids over to the grandparents' house very much because of the conflict with this other member. So we begin to see siblings being more and more resentful and alienated from the family as well. And we begin to see, from a system perspective, very rigid boundaries, which basically mean it's hard for new information to come in, because it sort of is limited, but it's really hard for helpful information to get out. So they not only can't, as these boundaries get more rigid, that helpful information tends to be rejected, and cries for help tend to get stifled. And so the family becomes more organized. And so if that's the case, then the internal boundaries between the parent subsystem or the marital subsystem becomes more diffuse, and that's where we begin to see that issue of enmeshment, where everyone's connected. That's why I picked this picture, that everyone isn't just holding hands here, they're connected to one another. And so if this person, let's say this one decides, this is too difficult and too painful for them to get out of that system, requires an impact on everyone in that system. And so people tend to stay put and tend to just live within those rules. So given that information can't come in or out, there's a lack of support, a lot more covert rules of people talking behind the addicted family members' back in an attempt to help them, but they often are very resentful of those. And so that idea of organizing around the problem. And that's a complicated issue to talk about, so try to do it so quickly. But I think this picture shows it beautifully. And so this was done by Laurel Kisser from, she's from the University of Maryland Medical School in Baltimore. And she's an expert in family trauma. And she said when a traumatic event happens, it doesn't just happen to the person who's the survivor, but that this event happens and everyone in the family and even intergenerationally responds to that in their own way. And again, we've talked about all of those responses. And so the kids have their own response. And it may, depending on age, may be very developmental and immature and childish. Or in adolescence and older siblings, where they move and kind of move backwards developmentally, or they isolate. The adults in the family begin to respond to that. And so I have traumatic, but it may be the addiction as it's progressing. And so each adult in that family is trying to solve and trying to help the family recover from these issues and doing the very best that they can. But they may be terrified. They may, when we go back and look at all of this, if they're experiencing these feelings and these cognitions and these defenses, are they going to be different? Is that relationship going to be the same relationship that it was prior to this? And I will tell you that often it is not. Relationships with extended family members and grandparents and other extended family members are responding to that because they all love whoever the primary trauma survivor is, and that they all have some element of secondary trauma. And then if you go to the next level, that each of these groups have relationships with each of these other groups. So from the kids' perspectives, their sibling relationships might be impacted. And again, if we go back to this, and we have this person who's struggling with addiction and maybe having all kinds of traumatic events, how does that change their relationship with their brothers and sisters or with other family members? How does that change their relationship with these parents or with the adults? And I just realized I left a slide out, and I'll address it Wednesday night when we meet. If the parents are different, is it going to impact the kids by suddenly the parents aren't as safe as they were because they're preoccupied, they're hypervigilant, and so the other kids don't get to do the things developmentally that they're supposed to do because the parents are terrified that the next kid in line is going to have the same addiction problem. As far as the adults, the parenting practices begin to change, and then their intimate relationships begin to change. And so if the intimate relationships begin to change, does that cause more anxiety and stress within the family, within the house? And that the kids are walking around on eggshells because while the parents are trying to keep the kids out of it, the kids can feel it immediately. And then as these sibling relationships and parent-child relationships and parenting relationships and adult intimate relationships are trying to find solution, that it begins to impact the entire family unit over time. And so if they can solve these at this level, or at this level first, and then interpersonally here, then this system has a really good chance to heal, and the system begins to operate and be okay. And so the last slide we're going to talk about today is, this is the marble map. Each person in this family has family history and this transgenerational impact. Everyone of these people has a limbic system and an amygdala that monitors and manages safety and hypervigilance. And so as this family comes together to talk about the struggles that they're having, it's not unusual for different people to be adjusting into that fight-flight response and to be defensive and to have different views or perceptions of what's going on. And so I always say that successful therapy is built on a foundation of really hard conversations. And so this is really what, in the next phase of our program, is helping families to have these conversations in a way that allows for healing rather than for increased conflict. So I think that's enough for this video, and I look forward to talking to you on Wednesday. I am also giving Annie an article that I wrote. It's kind of a scholarly journal, but it talks about family changes and family coping after traumatic events, and hopefully you will read it. And if you do, I want you to not look so much at so what I did was I went through all the different literature where trauma was common, like chronic diseases and things like that. But I would ask you to be more aware of the patterns and see if any of those patterns apply to what your family has been trying to deal with. And so we'll talk about it on Wednesday. Okay, thanks.